Usually when we talk about a medical diagnosis, there is this, I don't know, this comforting expectation of precision.
Right, yeah, like it's clear cut.
Exactly. If you fracture your radius, the radiograph shows this jagged white line. The orthopedic surgeon points right to it, and, well, that's the reality. It's totally binary, broken or not.
Yeah, the visual proof is right there.
Right. But when you step into the world of acute gastrointestinal emergencies, the diagnostic landscape is, it's rarely that clean. It is visceral, it's chaotic, and it's almost always hidden completely from the outside observer.
Oh, absolutely. It's a completely different environment.
I mean, I want you to picture a reality for a second. You, or perhaps someone you love, contracts just a routine illness. Maybe it's food poisoning from a bad restaurant or, a severe strain of influenza.
Standard stuff.
Yeah. The resulting vomiting is awful, of course, but it is entirely routine. You expect it. But then on the fourth or fifth violent heave, the expectation just shatters because unexpectedly, there is a terrifying massive volume of bright red blood.
Yeah, and for a patient, it is a moment of pure panic. The sudden transition from a mundane illness to what is suddenly a life-threatening hemorrhage, it's incredibly jarring.
Yeah, I can only imagine.
And for the clinical team waiting in the emergency department, that presentation triggers this immediate, highly coordinated race against the physiological clock.
Exactly. So what breaks inside the human body to cause such sudden failure? Today, we are taking you on a comprehensive clinical exploration of Mallory-Weiss syndrome, or MWS.
A really fascinating topic.
It really is. We've been looking through a massive stack of clinical management guides, surgical protocols, and peer-reviewed literature on upper gastrointestinal bleeding. And our goal here is to equip you with the deep structural insights needed to understand how clinicians recognize, stabilize, and actually treat this condition.
Quick, we need to look at the exact cellular failures,
Right.
The physiological vulnerabilities that prime the tissue to tear in the first place.
Yeah, we are moving way past the surface symptoms and diving into the literal mechanics of the human body breaking under pressure.
And the incredibly complex interprofessional gauntlet a patient actually has to navigate to survive a severe hemorrhage. It requires an understanding of fluid dynamics, pharmacology, and microscopic anatomy all at once.
It's a lot. And I'm thrilled to have you here to guide us through the complex pathophysiology behind those protocols. I'll be acting as the proxy for you, the listener, making sure we translate these intense physiological cascades into concepts we can all, visualize.
I'm looking forward to it.
Okay, let's unpack this. Before we talk about how a trauma team manages the bleeding, we have to understand the physical injury itself, like what is actually tearing.
Right, so we are looking at a very specific type of longitudinal mucosal laceration. And to really understand the context, we should look back to 1929.
1929, so Prohibition era.
Exactly. Two physicians, Kenneth Mallory and Mallory-Weiss, were conducting autopsies in Boston. And during the height of Prohibition, they were seeing an influx of patients suffering from the effects of severe binge drinking.
Because they were consuming, bathtub gin, that sort of thing.
Yeah, highly toxic illicit alcohol. And this induced uncontrollable violent retching. So on autopsy, Mallory and Weiss discovered these distinct linear tears right at the esophagogastric junction.
Okay, wait. They were finding these tears post-mortem, meaning the bleeding was severe enough to be fatal before modern interventions even existed.
That's right. It was a completely lethal event for many of these patients.
You mentioned the esophagogastric junction. Let's kind of zoom in on that specific real estate. Why does it tear there, of all places?
Well, the esophagogastric junction, clinically we refer to it as the Z-line, is the anatomical border where your esophagus meets your stomach. It's a transition zone.
Okay.
The stomach is lined with a really tough, thick, simple columnar epithelium. It's designed to secrete and withstand highly corrosive gastric acid.
Because it's basically a vat of acid, right?
Exactly. The esophagus, however, is just a transit tube. It is lined with stratified squamous epithelium, these flat, layered cells that are really just designed to handle the mechanical friction of swallowed food.
Okay, so you have two very different tissues meeting.
Right. The Z-line is where these two fundamentally different architectural structures literally join together.
It's almost like it's like sewing a heavy denim panel directly onto delicate silk.
That is actually a highly accurate way to visualize it.
Yeah.
In mechanical engineering, we call this a stress riser.
A stress riser.
Yeah. When you apply massive force to a structure made of two materials with totally different tensile strengths and elasticities, the failure almost always occurs right at the seam.
That makes perfect sense.
So in Mallory-Weiss syndrome, we see a single tear usually 1 to 2 centimeters long, occurring right at that seam or just slightly below it in the stomach. And crucially, the tear is superficial.
Meaning it doesn't go all the way through the wall.
Exactly. It is confined to the mucosa and submucosa, the innermost layers.
So it's basically a surface scratch, but it taps into a really rich vascular bed. Let's talk about the force required to rip that tissue. Because when someone vomits, the stomach is just emptying itself. How does that generate enough mechanical shear force to actually split the lining?
Well, the act of violent retching is not a passive emptying. It is a massive, sudden, and often poorly coordinated physiological explosion.
Explodes.
Literally.
Okay. Yep.
When you heave, you experience an extreme spike in intra-abdominal pressure. Your abdominal wall muscles contract violently.
Okay.
And simultaneously, your diaphragm, that massive dome-shaped muscle separating your chest from your abdomen, it spasms downward. The stomach is suddenly crushed between these two massive muscle groups.
No, the pressure inside the stomach must just skyrocket.
It does. We are talking about intragastric pressures exceeding 150 millimeters of mercury in just a fraction of a second.
Wow.
Normally, a coordinated vomiting reflex involves the complete relaxation of the lower esophageal sphincter, right? This allows the contents to freely escape upward.
The door opens, the fluid leaves.
Exactly. But in the violent repetitive spasms that lead to a tear, that neuromuscular timing completely fails. The sphincter might be partially closed, or the esophageal muscles might be actively contracting in the opposite direction.
So the stomach contents are essentially launched upward like a liquid cannonball, but they hit a closed door.
Yes. The kinetic energy of that fluid wave just slams into the esophagogastric junction. The tissue is subjected to massive shear forces. The mucosa simply cannot stretch fast enough to accommodate that explosive pressure differential, and the Z-line splits.
But I have to push back on this a little bit. I mean, the stomach is literally a muscular bag designed to churn heavy meals and handle the pressures of digestion.
Yep.
And evolutionarily, we are designed to vomit to expel toxins. If this system is built to handle pressure, why does this specific failure happen so frequently? The data in our sources shows this accounts for up to 10% of all nonvariceal upper GI bleeds. That feels really high for a system supposedly designed to handle occasional retching.
You are touching on a critical concept here: the difference between pristine anatomy and compromised tissue.
Okay, explain that.
In a healthy young individual with a perfectly intact mucosal barrier, the tissue possesses incredible viscoelasticity. It can stretch and deform without tearing, even under extreme pressure. But clinical data reveals that most patients who suffer a Mallory-Weiss tear do not have pristine tissue. Their mucosa has been silently degraded.
Degraded how? Like from diet?
Primarily through chronic inflammation. The clinical literature points heavily to chronic gastroesophageal reflux disease, or GERD.
Oh, acid reflux.
Right. When acidic gastric contents routinely splash up onto that delicate squamous epithelium of the esophagus over years, it causes chronic microinflammation.
So it's constantly irritated.
Exactly. The tissue undergoes cellular changes, becoming friable. Friable tissue loses its elasticity, it becomes brittle and highly prone to bleeding.
And alcohol does the same thing.
Yes. Chronic alcohol consumption induces a direct toxic effect on the mucosal lining. It literally strips away the protective mucus layer and induces localized ischemia.
Wow. So you have this natural architectural weak point, the seam, and then you chemically degrade it with acid or alcohol for years until it becomes brittle. Then you introduce the explosive kinetic energy of a violent retch, and the tissue just snaps.
That is the exact perfect storm.
That makes perfect sense. But if chronic tissue degradation is the primer, who is the typical patient actually walking through the ER doors with this?
The epidemiological profile is actually highly distinct. The mean age of presentation in the United States is roughly 56 years old. And there is a massive gender disparity. Approximately 72% of these patients are male.
Nearly 3/4 are men in their mid-50s. What is driving that specific demographic skew?
It correlates directly with the primary risk factor identified in the literature: excessive and chronic alcohol use. The sources indicate that alcohol is an underlying factor in 50 to 70% of all Mallory-Weiss cases.
That is a dominant driver. But beyond just making the tissue friable, like we talked about, how does the alcohol abuse specifically orchestrate the tear? Like, what's the mechanism?
Alcohol acts as a triple threat in this pathology. First, as we established, it causes chronic mucosal injury, severely reducing the tensile strength of the Z-line.
Right.
Second, chronic alcohol abuse frequently leads to alcoholic neuropathy, which alters the normal peristaltic motility of the esophagus and the relaxation of the sphincter.
So the coordination is broken.
Exactly. That neuromuscular timing we discussed earlier becomes severely compromised. And third, excessive consumption directly irritates the gastric lining, triggering the exact, violent, prolonged emesis required to spike the intragastric pressure.
So it weakens the wall, breaks the valve mechanism, and then fires the cannon.
That's a great way to put it.
But the sources also clearly state that vomiting from other causes can trigger this, right? It is not exclusively an alcohol-related syndrome.
Oh, far from it. Any underlying condition that precipitates recurrent, forceful vomiting places a patient at high risk. The etiology is really broad.
Like what else?
We see this frequently in patients presenting with diabetic ketoacidosis, where severe metabolic derangement causes profound nausea.
Okay.
We see it in end-stage renal failure patients due to uremia. It is a well-documented and highly dangerous complication of hyperemesis gravidarum.
Which is the really severe, intractable nausea and vomiting sometimes experienced during pregnancy, right?
Yes, exactly. And we see it in psychiatric populations, specifically patients battling bulimia nervosa, where the chronic self-induced vomiting places just unrelenting mechanical stress on the esophagogastric junction.
It really is the physical mechanism of the vomiting, regardless of the chemical trigger. But, reading through the management guidelines, there was a detail that completely stopped me in my tracks.
Oh, really?
You don't actually have to vomit to tear this tissue.
That is a vital clinical pearl. The tear is a pressure phenomenon, not strictly a vomiting phenomenon. Anything that generates a sudden, massive spike in intra-abdominal pressure can shear the compromised tissue.
Really? Like what?
We see patients who present with Mallory-Weiss tears after severe paroxysmal coughing fits, perhaps from pertussis or severe COPD exacerbations. We see it from heavy lifting, where an individual performs a Valsalva maneuver, bearing down and holding their breath.
Wow, just holding your breath and lifting.
Because it artificially spikes the pressure gradients in the thorax and abdomen.
The fact that just coughing too hard or lifting a box can rip your stomach lining is deeply unsettling.
It really speaks to the fragility of the compromised mucosa. We even see it initiated by violent straining during a bowel movement.
Unbelievable.
And, more alarmingly, in the emergency setting, it is a known complication of cardiopulmonary resuscitation.
Wait, CPR?
Yes. The sheer mechanical force of external chest compressions violently alters the pressure dynamics between the chest and the abdomen. It can induce a mucosal tear, even in a completely unconscious patient.
And what about iatrogenic causes, like the medical procedures themselves?
Yes, the medical field itself is responsible for a subset of these injuries. A Mallory-Weiss tear occurs as a complication in roughly 5.4% of standard endoscopic procedures.
5.4%, that's not a small number.
No, it's not. Passing a flexible tube down the esophagus can induce violent gagging and retching if the patient is not adequately sedated, causing them to basically tear their own tissue against the instrument.
Oh, wow.
It also occurs during transesophageal echocardiograms, though much less frequently, around 0.07 to 0.49% of the time.
I want to return to the concept of tissue vulnerability for a second. The sources mention comorbidities like hiatal hernias being present in about 20% of cases.
Yeah.
Does a hernia fundamentally change the anatomy in a way that causes the tear?
It is an important distinction. The current understanding is that a hiatal hernia, which is where a portion of the stomach protrudes upward through the diaphragmatic hiatus into the chest cavity, it doesn't independently cause the tear.
Okay, so it's not the root cause.
No. However, it alters the local pressure dynamics. But more importantly, the herniated pouch acts as a reservoir. It traps highly acidic gastric juice directly against the Z-line.
Ah, so it's just bathing the tissue in acid.
Exactly. This exacerbates the local inflammation and tissue friability, perfectly priming the area to fail when a pressure spike actually occurs.
Got it. And what about medications? Millions of people take NSAIDs like ibuprofen daily for joint pain, or they are on complex anticoagulant regimens for atrial fibrillation. Do these medications weaken the Z-line?
Clinicians must be very precise with this distinction. Non-steroidal anti-inflammatory drugs, NSAIDs, and anticoagulants do not cause the structural tear.
They don't.
No, they do not increase the risk of the physical laceration occurring. However, they drastically alter the clinical outcome if a tear does occur.
How so?
An NSAID inhibits platelet aggregation. An anticoagulant directly interrupts the coagulation cascade. So if a patient on these medications suffers a tear, they cannot form a stable fibrin plug.
Oh, so they just keep bleeding.
Yes. A minor mucosal scratch that would normally clot off unnoticed becomes a massive, life-threatening hemorrhage.
The body's natural defense mechanism has basically been therapeutically deactivated.
Precisely.
But looking at the broader epidemiological data, I have to challenge a specific statistic in the text. It explicitly notes that up to 20% of patients present without any identifiable risk factor.
Yes, that's true.
No alcohol abuse, no hyperemesis, no hiatal hernia, just a perfectly healthy individual.
Yeah.
If we rely on algorithms looking for a 56-year-old alcoholic male, aren't we setting ourselves up for massive diagnostic failure in the ER? Why are these anomalies happening?
That 20% figure represents a significant clinical blind spot. And it is exactly why treatment protocols demand that the immediate physical presentation overrides the patient history. If a healthy 30-year-old walks in vomiting blood after a single bout of food poisoning, you cannot dismiss the diagnosis just because they don't fit the demographic profile.
Right. But physiologically, what is happening to those 20%? If their tissue isn't degraded by alcohol or acid, why did it tear? Are we missing something deeper, perhaps subclinical connective tissue disorders?
That is an area of intense speculation and ongoing research right now. It is highly probable that within that 20%, we're looking at undiagnosed subclinical variations in collagen cross-linking.
Like genetic differences.
Exactly. The structural integrity of the submucosa relies heavily on type 1 and type 3 collagen. Minor genetic variations in collagen synthesis, perhaps extremely mild phenotypes of conditions like Ehlers-Danlos syndrome, could leave the esophagogastric junction with a slightly lower tensile strength.
So they live their whole lives without issue, until one severe retch generates a pressure wave that perfectly hits their specific threshold for structural failure.
Yes, or we might also be looking at microscopic, undiagnosed, sliding hiatal hernias that alter the geometry just enough to focus the shear force on a single microscopic point.
That makes the clinical picture incredibly complex. You have a patient population where 80% have obvious chemical degradation and 20% might have hidden architectural flaws.
Exactly.
This means the emergency physician cannot rely on a checklist of risk factors. They have to read the immediate symptoms. So let's bring the patient into the emergency bay. What is the classic textbook presentation of this tear as it unfolds?
The hallmark presentation is highly specific and sequential. It begins with an episode or several episodes of nonhemorrhagic vomiting.
Normal vomiting.
Right, the patient is vomiting normal gastric contents, clear fluid, or bile. It looks like standard gastroenteritis. But then, on a subsequent heave, there was a sudden onset of hematemesis, the vomiting of blood.
That sudden shift is the exact moment the seam rips.
Precisely. And the hematemesis can be bright red, indicating brisk, active arterial bleeding. Or it can present as dark, coffee ground emesis.
Coffee ground, like literally looking like coffee grounds.
Yes, that's the classic description. Coffee ground emesis means the bleeding occurred, pooled in the stomach, and the hemoglobin was oxidized by the gastric acid.
Yeah.
This turns it dark and granular before it was finally vomited up.
Wow. And if the bleed is massive and rapid, what other signs does the body project?
The clinical presentation cascades rapidly based on blood volume loss. If the blood transits downward through the gastrointestinal tract, the patient will present with melena,
Which is?
the passage of black, tarry, highly foul-smelling stool. This indicates the blood has been completely digested as it moves through the intestines.
Oh, grim.
Very. And in cases of catastrophic rapid hemorrhage, you may see hematochezia, which is the passage of bright red blood from the rectum. The blood is moving through the system so quickly that the digestive enzymes haven't even had time to break it down.
While that blood is pouring out, what is happening systemically? Like, how does the lack of blood volume manifest in their vital signs?
The patient enters hypovolemic shock.
Yeah.
As intravascular volume depletes, the baroreceptors in the aortic arch detect the drop in pressure. The sympathetic nervous system triggers a massive release of catecholamines, epinephrine, and norepinephrine.
Adrenaline, basically.
Yes, this causes profound peripheral vasoconstriction. It shunts blood away from the skin and extremities to protect the brain and heart, so the patient will appear ghost white or pallid.
Because there's literally no blood in their skin.
Right. Their heart rate will skyrocket tachycardia as the heart desperately tries to maintain cardiac output with less fluid, and they will exhibit orthostatic hypotension. If they attempt to sit up, gravity pulls the remaining blood down, their pressure bottoms out, and they experience syncope or fainting.
All of this sounds incredibly violent and terrifying, but the clinical literature points out something deeply counterintuitive. The tear itself is generally painless.
It is a critical, almost paradoxical feature of the syndrome. Unless a complication develops, the actual laceration of the mucosa does not generate pain.
How is it possible to tear the lining of an organ and not feel it? I mean, if I scratch my cornea, I am in agony.
It comes down to the neuroanatomy of the gastrointestinal tract. The superficial layers, the mucosa and submucosa, have a relatively sparse distribution of somatic pain-sensing nerve fibers compared to the external skin or the cornea.
Oh, I see.
The visceral afferent nerves in the gut are designed to sense stretch and distension, not necessarily localized sharp trauma. Therefore, a purely mucosal tear is a silent mechanical failure. The patient feels the nausea and the physical exertion of the vomiting, but they do not feel the tear happen. They only realize they are injured when the blood appears.
This brings us to a terrifying crossroads for the ER physician. The patient is vomiting blood, their heart is racing, but their chest doesn't hurt. You mentioned this absence of pain is actually a vital diagnostic clue to differentiate Mallory-Weiss from something much more lethal, Boerhaave syndrome. Walk us through that differential.
The distinction between Mallory-Weiss syndrome and Boerhaave syndrome is quite literally the difference between an urgent endoscopic intervention and immediate life-saving thoracic surgery. As we established, a Mallory-Weiss tear is mucosal. It is superficial.
Right.
Boerhaave syndrome, which is also caused by violent retching, is a full-thickness transmural rupture of the esophagus. The pressure wave doesn't just split the inner lining, it blows a hole completely through the muscular wall of the esophagus.
A total blowout.
Yes. And when the esophagus ruptures, highly acidic gastric juice, undigested food particles, and oral bacteria pour out of the digestive tract and directly into the mediastinum,
Which is what? The chest cavity.
the central compartment of the chest cavity that houses the heart, the great vessels, and the trachea.
That sounds immediately fatal.
Without rapid surgical intervention, the mortality rate approaches 100%. The leak contents cause acute chemical mediastinitis, leading to overwhelming sepsis and multi-organ failure.
My God.
Because the rupture breaches the deeper muscular layers and the parietal pleura, which are densely innervated with pain receptors, Boerhaave syndrome presents with excruciating, tearing chest pain that often radiates to the back or left shoulder.
So if a patient is vomiting blood but is pain-free, the physician breathes a slight sigh of relief, suspecting Mallory-Weiss. If the patient is writhing and tearing chest pain after retching, the physician immediately activates the surgical team.
Exactly. It's a completely different pathway.
But Boerhaave isn't the only mimic on the board, right? The differential diagnosis for an upper GI bleed is massive. You have bleeding peptic ulcers, which are incredibly common. You have pill-induced esophagitis, where a daily medication gets lodged and chemically burns an ulcer into the mucosal wall. And you have bizarre vascular anomalies like Dieulafoy lesions, where a freakishly large, tortuous artery protrudes through the stomach lining and just spontaneously ruptures.
Yes, the physician must keep a very broad differential. But the most dangerous mimic, especially given the heavy correlation with chronic alcohol abuse, is a bleeding esophageal varix.
Let's dive deep into that. Why is a ruptured varix the nightmare scenario in the trauma bay?
To understand varices, we have to look at the hemodynamics of the liver. In a patient with severe chronic alcohol abuse, the liver undergoes cirrhosis. Healthy hepatic tissue is replaced by dense fibrotic scar tissue.
Okay, so the liver becomes stiff?
Right. This scarring dramatically increases the vascular resistance within the liver. The portal vein, which drains blood from the entire gastrointestinal tract into the liver, suddenly faces a massive roadblock. The pressure within the portal venous system skyrockets. This is portal hypertension.
The blood has to go somewhere. I mean, the pressure has to release.
Exactly. The body attempts to decompress the portal system by opening up collateral circulation detour routes that bypass the liver to get the blood back to the heart.
Okay.
One of the primary detour routes utilizes the veins at the distal end of the esophagus. These thin-walled superficial veins are suddenly subjected to massive unnatural venous pressures. They engorge, balloon out, and become tortuous. These are esophageal varices.
They're essentially high-pressure venous aneurysms lining the inside of the throat.
And their walls are incredibly fragile. Now, place that patient and alcoholic with massive portal hypertension and engorged varices into a scenario where they experience a bout of violent vomiting. The massive spike in intrathoracic pressure could cause a superficial Mallory-Weiss tear, or that exact same pressure spike could cause one of those high-pressure varices to rupture.
And from the outside, the ER physician just sees a patient vomiting a terrifying amount of blood. There's no pain either way.
Exactly. But the pathophysiology of the bleed is entirely different. A Mallory-Weiss tear is typically an arterial or capillary bleed from a small vessel in the submucosa. A ruptured varix is an explosive, high-volume venous hemorrhage driven by portal hypertension.
So the treatment has to be different.
The variceal bleed requires entirely different immediate pharmacological interventions. The physician must instantly administer intravenous vasoactive drugs, like octreotide, which causes splanchnic vasoconstriction to reduce blood flow into the portal system, thereby lowering the pressure in the ruptured varix. If they misdiagnose the bleed and simply wait for a standard endoscopy, the patient will exsanguinate. They will bleed to death right on the table.
So the diagnostic uncertainty is absolute. You have a patient in shock, bleeding internally, and you don't know if you're dealing with a leaky scratch, a burst ulcer, or an exploded high-pressure vein.
It's a high-stress scenario.
I mean, the instinctive reaction, my reaction as a layman, would be to immediately rush a camera down their throat to find the source and stop it. Just get in there and look. But reading the clinical guidelines, that instinct is not just wrong, it is considered medical malpractice.
It is arguably the most dangerous cognitive trap in the management of acute gastrointestinal bleeding. The psychological desire to fix the hole must be completely suppressed. The clinical protocols are absolute and they're written in blood over decades of trial and error.
Which is?
The undisputed paramount priority is the assessment and resuscitation of the patient's hemodynamic status. You do not treat the anatomical defect, you treat the physiological shock.
Let's break down the physiology of that shock management. The tank is emptying. The heart is racing. What are the clinical rules of engagement before a scope is ever considered?
The moment the patient hits the bay, you secure access. The team places 2 large-bore intravenous lines, usually 18 gauge or larger, in the peripheral veins.
Because you need to push fluid fast.
Right. You cannot push the necessary volume of fluid through a standard small fee. Blood is immediately drawn for a complete blood count, a comprehensive metabolic panel to check renal and hepatic function, and crucial coagulation studies, prothrombin time and INR, to see if the patient's blood is even capable of forming a clot.
But you don't wait for the lab results to come back before acting.
Right, never. If the patient is exhibiting signs of hemodynamic instability, tachycardia, hypotension, or an altered mental status indicating brain hypoperfusion, you immediately initiate aggressive fluid resuscitation. You push intravenous crystalloids like normal saline or lactated Ringer solution at maximum speed.
You are just aggressively filling the pipes with salt water to keep the systemic pressure high enough so the brain and kidneys don't undergo ischemic death.
Yes, you are buying time. But crystalloids do not carry oxygen. If the bleeding is massive, the patient's hemoglobin drops. The clinical threshold is firmly established. If the hemoglobin level falls below 8 grams per deciliter or a slightly higher threshold of 9 to 10 in patients with severe cardiovascular disease who cannot tolerate ischemia, the crystalloid resuscitation must immediately transition to blood products.
So you start transfusing.
You activate the blood bank and transfuse packed red blood cells to restore the blood's oxygen-carrying capacity.
Okay, I want to drill down into the why here. I understand the need to keep the patient alive, but if the source of the bleeding is a gaping tear, why is it so incredibly dangerous to just sedate the patient, drop the scope, and put a clip on the bleeder immediately? Why? Wait.
To understand the danger, you have to look at the pharmacology of endoscopic sedation, interacting with the physiology of hemorrhagic shock. To pass a flexible endoscope down a patient's esophagus, you must suppress their gag reflex and keep them perfectly still. If they thrash or retch against the scope, they will cause further iatrogenic tearing.
Right.
Therefore, the anesthesiologist uses potent sedatives and induction agents, drugs like propofol, fentanyl, or midazolam.
Standard anesthesia.
But these drugs have profound systemic effects. Propofol, for instance, is a potent vasodilator. It causes the smooth muscle and the blood vessel walls to relax, opening the pipes wide. It also depresses myocardial contractility. It physically weakens the pumping force of the heart.
Okay, and why is that bad here?
Well, look at your patient. They have lost 2 liters of blood. Their body is only surviving because the sympathetic nervous system is screaming at the blood vessels to clamp down tightly massive vasoconstriction, and the heart is beating at 130 beats per minute just to maintain pressure.
Oh. The body is doing everything it can to artificially squeeze the remaining blood up to the brain.
Exactly. Now, what happens if you push a bolus of propofol into that fragile hypovolemic ecosystem? You instantly strip away the sympathetic tone. The desperately constricted blood vessels suddenly dilate wide open. The heart muscle weakens. The compensatory mechanisms vanish in a matter of seconds. The
Whoa.
blood pressure bottoms out to near zero, perfusion to the coronary arteries fails, and the patient goes into full cardiac arrest on the endoscopy table. The intervention kills them faster than the hemorrhage.
That is a brilliant, terrifying explanation. You literally pull the physiological rug out from under them.
Therefore, the timing protocols are strictly defined by the patient's physiological stability. If the patient is hemodynamically stable, their blood pressure is holding, their heart rate is normal, the endoscopy should be performed within 12 hours of admission. It is urgent, but not emergent. If the patient is unstable, they require aggressive resuscitation first. The scope is ideally performed within 24 hours, but only after stability is achieved and the tank is refilled.
So you buy them time. But surely the medical team isn't just standing around watching saline drip into a vein. Are there pharmacological interventions utilized during this waiting period to directly target the tear, even before the camera goes in?
Absolutely. The pre-endoscopic medical management is vital to survival. The undisputed standard of care is the immediate administration of high-dose intravenous proton pump inhibitors, or PPIs. The protocol typically involves a massive 80 milligram bolus push, followed by a continuous intravenous infusion at 8 milligrams per hour.
PPIs, drugs like pantoprazole or omeprazole, those are acid reducers. Why on earth are we concerned about stomach acid when the patient is actively bleeding to death?
Because gastric acid is the mortal enemy of the coagulation cascade. Let's look at the cellular biology of a blood clot. When a vessel tears, platelets rush to the site and aggregate to form a physical plug. Then a protein called fibrinogen is cleaved into fibrin, which weaves a dense structural net over the platelets to lock the clot in place.
It's the body's natural spackle and mesh tape.
Exactly. But that cascade functions optimally at a neutral physiological pH around 7.4. The environment inside the stomach is violently acidic, with a baseline pH of 1.5 to 2.0.
Too acidic for clots.
In this highly acidic environment, platelet aggregation is severely impaired. But more importantly, the stomach secretes a proenzyme called pepsinogen. In the presence of high acid, pepsinogen converts into its active form, pepsin. Pepsin is a powerful proteolytic enzyme designed to digest proteins in your food.
And a blood clot is made of protein.
Yes. Pepsin literally attacks and digests the fibrin net. It dissolves the body's natural clot as fast as the body can build it. By blasting the patient's system with a high-dose IV PPI, you rapidly shut down the proton pumps in the parietal cells of the stomach lining. You completely halt acid secretion.
So the pH goes up.
The gastric pH rises above 6.0, pepsin is deactivated, and the environment becomes hospitable for the platelets and fibrin to form a stable, durable clot over the Mallory-Weiss tear.
That is fascinating. You are aggressively altering the local chemical environment so the body can patch its own leak while you wait for the patient's hemodynamics to stabilize. But what happens in the absolute worst-case scenario? What if the patient is bleeding so massively that you simply cannot keep up with transfusions, or their respiratory status is so compromised that you absolutely cannot risk sedation even after 24 hours? If endoscopy is contraindicated, are you out of options?
We are never out of options. If an EGD is absolutely contraindicated, or if the initial scope fails to locate the bleeding source because the stomach is too full of dark clots to see anything, the next algorithmic step is computed tomography angiography, or a CT angiogram.
A CT scan, but specifically calibrated for the vascular system.
Correct. The patient is moved to the scanner and a highly concentrated iodine-based contrast dye is injected rapidly into their IV. The scanner captures images in distinct circulatory phases. If there is an active arterial bleed, the scan will explicitly show a blush of contrast dye extravasating, leaking out of the specific gastric artery and pooling into the lumen of the stomach.
Like a glowing leak on the screen.
It provides a precise three-dimensional roadmap of the bleeding vessel without ever requiring a camera down the throat. This roadmap is vital for guiding the interventional radiologists, which is a salvage pathway we will discuss shortly.
The underlying philosophy is incredibly clear. Stabilize the fluid dynamics, neutralize the chemical environment, and only then proceed with structural visualization. This brings us to the actual intervention. The patient's vitals have stabilized. The IV fluids are running. The acid is completely suppressed. Now, the gastroenterologist can safely advance the scope to find the tear and stop the bleed. Walk me through this. What is the physical reality of this procedure?
The statistics regarding the endoscopic findings are actually quite staggering and deeply reassuring. Up to 90% of Mallory-Weiss tears resolve spontaneously without any requirement for endoscopic therapy.
Wait, 90%. So 9 times out of 10, by the time the camera actually reaches the esophagogastric junction, the high-dose PPIs and the body's natural clotting cascade have already won the battle.
Exactly. When the endoscopist carefully advances the scope down the esophagus and retroflexes into the cardia of the stomach, they will locate the mucosal laceration. If they observe a clean, white-based tear with no active hemorrhage, no oozing blood, no visible spurting artery, and no thick, unstable clot adherent to the wound bed, they do absolutely nothing mechanically. No clips, no injections. The rule is, do not disturb the healing lesion.
You just visually confirm the diagnosis and carefully retreat.
Correct. The medical management simply continues. The patient remains on high-dose PPIs to promote rapid mucosal healing. Equally important, they are placed on strict, round-the-clock, intravenous antiemetic medications like ondansetron, which blocks serotonin receptors in the brain's chemoreceptor trigger zone, or promethazine.
To stop the vomiting.
The goal is to entirely paralyze the vomiting reflex. If the patient heaves even once, they could physically rip the fragile fibrin clot right off the healing tear.
But let's look at the other 10%. The high-risk cases where the scope goes down and the stomach is a crime scene. Active, bright red arterial spurting. What is the immediate physical maneuver?
If there is active hemorrhage, or if there are high-risk stigmata of recent bleeding, such as a visible non-bleeding vessel protruding nakedly from the tear, just waiting to burst again, endoscopic intervention is the absolute first-line therapy, and it is highly efficacious. Hemostasis is successfully achieved in over 90% of these active cases.
I want to understand the physical mechanics of fixing an artery through a tube. You are looking at a tiny screen controlling a long, flexible fiber optic cord inside a breathing, moving patient. You have a few options that can be deployed through the tiny working channel of that scope. The guidelines divide these into injection therapies and mechanical methods. Let's start with the chemistry. What is injection therapy?
The standard injection therapy utilizes dilute epinephrine, which is synthetic adrenaline. The endoscopist passes a specialized retractable scleral therapy needle through the working channel. They position the needle directly adjacent to the bleeding tear, pierce the mucosa, and inject the epinephrine into the surrounding submucosal tissue.
How does injecting adrenaline stop a bleed?
It works via a dual mechanism. First, the pharmacological effect. Epinephrine is a potent alpha-adrenergic agonist. It binds to the receptors on the smooth muscle of the local blood vessels, forcing them into profound, immediate vasoconstriction. It chemically clamps the bleeding artery shut.
And the second mechanism?
The mechanical effect. The actual physical volume of the fluid injected into the tight submucosal space creates a localized swelling, a bleb. This bleb physically compresses the bleeding vessel from the outside, a localized tamponade effect.
It sounds highly effective. It chemically constricts the pipe while simultaneously squeezing it shut from the outside. But the clinical protocol suggests that relying solely on epinephrine is a flawed strategy.
Because the effects of epinephrine are entirely transient. As the local tissue metabolizes the adrenaline, the pharmacological vasoconstriction wears off. The physical fluid bleb is eventually absorbed into the lymphatic system.
So the effect fades.
Once those dual effects dissipate, the vessel relaxes. If the physical hole in the arterial wall has not completely clotted over in that short window, the hemorrhage will abruptly resume. Therefore, the guidelines strongly advocate that epinephrine should only be used to temporarily slow the bleeding and clear the visual field. The definitive fix requires mechanical methods.
Let's discuss those mechanical methods. The two primary tools mentioned are hemostatic clipping and endoscopic band ligation. Explain the clip to me. I envision it like stapling a wound shut, but it has to be more complex than that.
The stapler analogy is decent, but let's look at the engineering of a hemoclip. It is a tiny metallic device with 2 or 3 prongs, preloaded onto a flexible delivery catheter. The endoscopist passes the catheter through the scope. The physical challenge here is immense.
Why is that?
The scope is in a retroflexed U-turn, looking upward at the Z-line. The stomach is pooled with blood. The patient is breathing, meaning the target tissue is constantly shifting up and down with the diaphragm.
It is like trying to clamp a burst pipe in the dark while the room is actively flooding and the pipe itself is moving away from you.
That is an incredibly accurate description of the endoscopic environment. The physician must wait for the exact moment the tissue aligns, open the prongs of the clip, press the device firmly against the bleeding vessel and the surrounding mucosa, and fire the deployment handle.
Snap it shut.
The metallic prongs snap shut with significant force, physically gathering the tissue, crushing the bleeding vessel, and pulling the edges of the mucosal tear tightly together.
A durable mechanical seal.
Exactly. The clip completely cuts off the blood flow and holds the tissue immobile. The clip remains embedded in the mucosal wall for weeks, allowing the defect to heal completely underneath it. Eventually, the necrotic tissue holding the clip sloughs off, and the clip harmlessly passes through the digestive tract.
And what about band ligation? I know that technique is heavily utilized for the varices we discussed earlier, but how do you rubber band a flat longitudinal tear?
Band ligation requires a specialized attachment. The endoscopist withdraws the scope, attaches a small transparent plastic cap to the tip, and reinserts it. This cap is preloaded with tiny, highly elastic rubber bands. The endoscopist maneuvers the cap directly over the bleeding point on the tear and activates aggressive suction.
Like a vacuum hose.
Precisely. The suction physically pulls the actively bleeding mucosa and the underlying vessel up into the hollow cap, creating a pseudopolyp of tissue. Once the tissue is fully aspirated into the cap, a deployment wire rolls one of the rubber bands off the edge of the cap and tightly around the base of the suction tissue.
It strangulates the entire vascular supply to that specific focal point.
Yes. The banded tissue rapidly becomes ischemic, necrosis, and sloughs off a few days later, leaving a shallow, healing ulcer in its place.
The data clearly shows these mechanical methods, the clips and the bands, demonstrate far greater efficacy than injection alone for achieving initial hemostasis, and crucially, for preventing rebleeding. The rebleeding rate sits at around 7% within the first 24 hours. But what happens when the mechanical tools fail? What if the tear is just too large, or the tissue is so severely degraded from decades of alcohol abuse that the metallic clips just tear right through the friable mucosa like wet paper? What is the salvage therapy?
When standard mechanical therapies fail, or when the bleeding is so catastrophic that the endoscopist cannot even visualize the lesion to deploy a clip, we move to a relatively novel salvage tool, hemostatic powder spray. The endoscopist passes a specialized catheter and sprays a proprietary inorganic, mineral-based powder under high pressure directly into the general area of the hemorrhage.
You just dust the crime scene.
It is highly advanced chemistry. When this specific powder comes into contact with moisture, specifically the water content in blood, it instantly undergoes a phase change. It gels and rapidly cross-links, forming a highly cohesive mechanical matrix over the entire bleeding surface.
Like an instant scab.
Exactly. It acts as an instant solid barrier, providing immediate, albeit temporary, hemostasis. It buys the critical time needed to prepare the next echelon of intervention.
And if the powder fails, or the bleed is simply unmanageable from the inside of the stomach, we return to the CT angiogram we discussed earlier, and the interventional radiologist steps in.
Exactly. This is the ultimate, minimally invasive salvage pathway. Transcatheter arterial embolization. The patient is rushed to the interventional radiology suite. The radiologist accesses the arterial system, usually via the femoral artery in the groin or the radial artery in the wrist. Utilizing real-time fluoroscopic X-ray guidance, they thread a microcatheter all the way up the aorta, navigating into the celiac trunk, and selectively cannulate the specific left gastric artery that is feeding the Mallory-Weiss tear.
They are navigating the vascular tree from the inside, following the branches right to the bleeding leaf.
Yes. Once the tip of the microcatheter is positioned millimeters away from the bleeding hole, they inject embolic agents. These can be tiny platinum microcoils that physically jam the vessel, or gelatin sponge particles that initiate an immediate, localized clot. They block the arterial blood supply from the inside out, completely starving the tear of its pressure source. It is an extraordinary display of anatomical precision that saves patients who would otherwise require open surgery.
It is truly remarkable, which perfectly sets up the final phase of this clinical journey. Fixing the tear, deploying that hemoclip, or embolizing that artery is a massive victory. But as we see with that 7% rebleeding rate in the first 24 hours, the danger is far from over when the scoop comes out or the catheter is removed. Patient survival relies on a perfectly coordinated sequence of care from multiple specialists over several days. Let's construct a clinical pathway. Let's invent a high-risk patient scenario and walk through their care from admission to discharge to illustrate how this orchestrated system actually functions.
Let's create a highly complex but very realistic presentation. We will call him a 65-year-old male. He have a significant cardiac history, severe coronary artery disease with the previous stent placement. Furthermore, he is in chronic atrial fibrillation, meaning his heart beats irregularly, increasing his risk of stroke.
Okay, so he's on meds for that.
Yes. To mitigate that stroke risk, He takes a daily direct oral anticoagulant, a powerful blood thinner. He presents to the emergency department vomiting large volumes of bright red blood after suffering a severe, prolonged bout of viral gastroenteritis.
The physiological clock starts. The baton is in the hands of the emergency medicine physicians. What is their immediate protocol?
The ER physician's sole focus is massive shock management and the immediate reversal of his iatrogenic coagulopathy. They recognize the lethal combination of his age, his cardiovascular disease, and his blood thinners. They establish large bore access. Because of his coronary disease, his heart cannot tolerate profound anemia. The lack of oxygen will trigger a myocardial infarction on top of the hemorrhage.
A heart attack while he's bleeding.
Right. They immediately initiate a massive transfusion protocol, pushing O-negative packed red blood cells alongside fresh frozen plasma to provide necessary clotting factors.
They are refilling the tank with oxygen-carrying fluid while simultaneously trying to rebuild the clotting cascade.
Yes. And concurrently, they must administer a specific pharmacological reversal agent tailored to his exact blood thinner, attempting to switch his body's clotting capability back on. Simultaneously, the nurses are pushing the 80 milligram IV PPI bolus to neutralize his gastric acid. Once his mean arterial pressure stabilizes and his hemoglobin hits an acceptable threshold, the ER physician contacts the gastroenterologist on call.
The baton passes to the GI team, but there has to be an intense synthesis of information here.
The communication must be flawless. If the ER physician fails to aggressively communicate that this patient has severe coronary disease and is on heavy anticoagulants, the result could be fatal. The endoscopist and the anesthesiologist need to know that this patient's cardiovascular reserve is nearly zero.
Because of the propofol risk we talked about.
Exactly. They cannot tolerate any profound drop in blood pressure from the sedation. Furthermore, the endoscopist knows that any mechanical intervention they perform must be absolutely perfect because the patient's underlying clotting cascade is severely compromised.
So the gastroenterologist and the endoscopy team set up the procedure in a highly controlled environment. They sedate him carefully, advance the scope, retroflex into the cardia, and locate the lesion. A 2.5 centimeter tear with an actively spurting artery. Because of his medications, the endoscopist knows a quick injection of epinephrine will fail. They meticulously deploy 3 hemoclips, locking the laceration shut like a zipper. The bleeding stops immediately. The scope is withdrawn. Now what? Does he just wake up and go to a standard hospital room?
Absolutely not. This patient remains in a highly precarious state. The clinical guidelines clearly dictate that patients with active coagulopathy, advanced age, or severe cardiovascular comorbidities require immediate admission to an intensive care unit or a high-acuity step-down unit. The baton passes to the critical care nursing team.
What are the ICU nurses monitoring over the next 48 hours?
They are monitoring every physiological parameter. They conduct continuous invasive hemodynamic monitoring, likely via an arterial line in his wrist, measuring his blood pressure beat by beat. They're watching for the slightest, subtle drop in pressure or a sudden spike in heart rate, the earliest indicators that the hemoclips have failed, and he is silently rebleeding into his stomach.
Constant vigilance.
Yes, and they manage the continuous intravenous PPI infusion, keeping it running at 8 milligrams per hour for up to 72 hours, ensuring the gastric pH remains artificially high while the initial submucosal healing occurs.
And what about the nausea?
That is critical. They administer strict, scheduled, round-the-clock antiemetics. They cannot wait for him to complain of nausea. They must proactively suppress the reflex. If he retches violently while waking up or shifting in bed, the sheer mechanical force will rip those hemoclips right off the friable tissue, and the massive hemorrhage will instantly resume.
Let's introduce a failure into the system. It's hour 14. The patient's blood pressure plummets from 120/80 down to 70/40. The monitor is alarmed. The nurse notes fresh, bright red hematemesis in his suction canister. The clips have failed.
The GI team is immediately notified, but because he is an incredibly high-risk patient whose first endoscopic therapy already failed, the interventional radiologist is activated and put on immediate standby. The team must rapidly decide if a second attempt at endoscopic clipping is feasible, or if the risk of repeat sedation is simply too high for his ischemic heart.
And if it's too high?
If the GI team decides against a second scope, the patient is rushed to the IR suite for the emergency transcatheter arterial embolization we described earlier, blocking the left gastric artery with microcoils.
And what about the final failsafe? You mentioned earlier that surgery is incredibly rare, but when do the general surgeons get the baton?
Surgery is the absolute last resort for the rarest, most fatal progression of the disease. If the patient's initial retching was so impossibly violent, or the Z-line tissue is so severely degraded that the mucosal tear physically progresses into a full transmural rupture,
Yeah.
essentially evolving into a delayed Boerhaave-like perforation, the minimally invasive options are exhausted.
Then you have to open them up.
The patient requires an immediate emergency laparotomy or thoracotomy. The surgical team must open the abdominal or chest cavity, physically oversew the massive rupture, and aggressively irrigate the highly infectious acidic gastric contents that is spilled into the sterile body cavities. It carries massive morbidity, but it is the ultimate failsafe.
But let's look at the optimistic outcome. Our 65-year-old patient avoids the complications. The hemoclips hold perfectly. His hemoglobin stabilizes over 72 hours in the ICU. He transitions from IV fluids to clear liquids on day 3 and eventually tolerates a soft diet. He is prepared for discharge. I want to shift focus to the patient's perspective at the end of this terrifying gauntlet. If I'm a patient being discharged, I might still be mentally minimizing the event. I might just think, wow, I had a really bad stomach bug that got a little out of hand, but they fixed it. How does the discharging physician communicate the gravity of recurrence prevention, especially regarding lifestyle modifications like alcohol, without the patient simply tuning them out?
That is perhaps the most difficult interprofessional challenge in the entire clinical pathway: effective, resonant patient education. It requires direct, unambiguous, and highly visual communication from the discharging physician and the nursing staff. You cannot couch the language in medical jargon. You must explain to the patient that they did not merely have a severe stomach bug, they suffered a catastrophic, life-threatening mechanical failure of their internal anatomy.
You literally have to make them understand the physics of what happened to the tissue.
Precisely. You must explain that their Z-line tissue is fundamentally vulnerable. If excessive alcohol consumption was the primary driver that weakened their tissue, this is a critical, life-saving intervention moment to discuss addiction medicine consults, rehabilitation programs, and the physiological reality that another binge could be fatal.
And if it was NSAIDs?
If the tear was exacerbated by heavy NSAID use, you must educate them on strictly avoiding ibuprofen and naproxen, steering them toward acetaminophen instead to protect their platelet function.
You essentially give them an operational manual for their compromised digestive tract.
Yes, they must be given absolute, clear instructions. If you ever feel nauseous again, for any reason, do not attempt to tough it out. You take your prescribed antiemetics immediately to suppress the pressure spike. And most importantly, if you ever vomit even a speck of blood, or if you ever pass a black tarry stool, you do not wait to see how you feel in the morning. You call for an ambulance immediately. The recurrence rate is real, and the next tear might not stop at the mucosal layer.
Because the preventative education, the behavioral modification, is just as critical to their long-term survival as the titanium hemoclip currently embedded in their stomach wall.
Exactly. Without addressing the underlying mechanical catalyst and the friability of the tissue, they will simply be back in the trauma bay within the year.
That is a phenomenal, exhaustive breakdown of the entire clinical ecosystem surrounding this condition. We've navigated from the microscopic cellular architecture of a shearing tissue interface, through the massive fluid dynamics of hypovolemic shock, into the physical engineering of endoscopic interventions, and finally the macroscopic choreography of a hospital system working in unison to save a life. As we wrap up this intense deep dive, can you synthesize the core vital tenets we've uncovered today?
Certainly. First, remember the fundamental mechanical nature of Mallory-Weiss syndrome. It is a shear force injury, a longitudinal mucosal tear generated by explosive pressure differentials, fundamentally driven by violent vomiting, coughing, or straining against a compromised esophagogastric junction.
Right.
Second, the golden rule of acute evaluation. Clinicians must absolutely prioritize hemodynamic resuscitation over immediate diagnostics. You treat the hypovolemic shock and stabilize the fluid volume before you ever consider passing a scope down an unstable bleeding patient.
Do not cause cardiac arrest with propofol.
Exactly. Third, while the vast majority of these tears heal spontaneously with high-dose PPIs in time when intervention is actively required, mechanical endoscopic therapies like hemostatic clipping are vastly superior for achieving durable hemostasis and preventing rebleeding. And finally, effectively managing these patients, especially those with severe comorbidities or active coagulopathies, requires a seamless, highly communicative interprofessional pathway stretching from the initial ER resuscitation all the way to comprehensive preventative discharge education.
It is an incredibly complex cascade of events, but deeply fascinating when you finally understand the why behind every clinical protocol and the how behind every physiological failure. As we leave you today, I want to pose a final lingering thought inspired by examining the underlying causes in these sources. We spent significant time discussing how chronic acid reflux GED reduces tissue resilience, causing microinflammation that makes the esophagogastric junction fragile and susceptible to these violent mechanical tears. We know that in our modern world, silent reflux, chronic physiological stress, and highly acidic processed diets are becoming nearly universally common. The architectural seams of our digestive tracts are under constant silent bombardment.
They are.
So the question is this. With the baseline health of our mucosal linings deteriorating, are we quietly priming an entirely new generation for Mallory-Weiss syndrome under the strain of what used to be just an everyday illness?
It is an excellent, highly relevant question. The degradation of our tissue resilience may be outpacing our evolutionary ability to adapt to modern dietary habits. It is something that should keep both clinicians and patients highly vigilant.
Something to seriously consider the next time you reach for an antacid after a heavy meal. Thank you for joining us on this deep dive. We encourage you to keep questioning the clinical mechanics behind the symptoms you see, to continually look past the surface presentation, and to always seek the why. Until next time.